Hello everyone. My name is Firas Al-Frey. I'm the president of Saudi Society for Blood Disorder. I would like to welcome you all to the last day of the annual Saudi Hematology Congress 2023. In today's session, we'll be having approximately 2 hours of a discussion regarding the use of CAR-T from different perspectives on different diseases. We have renowned speakers and moderators. So it's my great pleasure to introduce our moderators for today. So the first one is Dr. Syed Ahmed. He's an attending physician at King Faisal Specialist Hospital in Riyadh, as well as he's the medical director of Adult CAR-T program. Our second moderator is Dr. Mohsen Al-Zahrani, who is the chair of Department of Bone Marrow Transplant and CAR-T Cell at the National CAR-T Hospital, King Abdulaziz Medical City in Riyadh. Thank you all, and it's my pleasure to ask moderator to introduce the first speaker. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Firas, for the introduction and for inviting us to moderate the session today, which is the last day of the Congress. We have 5 lectures today, and I will introduce the first speaker, Dr. Robin Sanderson. It's my great pleasure to introduce Dr. Sanderson. He's a consultant hematologist at King's College Hospital, London, UK, and he is going to talk about CAR-T versus auto-BMT in lymphoma. So, Dr. Sanderson, you can start your presentation.
Good afternoon. Thank you for inviting me to speak at this meeting regarding the question CAR-T versus autograft in large B-cell lymphoma. I'm Dr. Robin Sanderson. I'm a consultant hematologist at King's College Hospital in London, and I run the CAR-T program there. So these are my disclosures. So just a reminder of the landscape for CAR-T in lymphoma. The 2 products that have been available for a number of years now are ASHC and Tisacel. Obviously, they have slightly different mechanisms of action in terms of their co-stimulatory domain, but their target, CD19, is the same. The companies are different, and ASHC is available for second-line and third-line large B-cell lymphoma and low-grade lymphoma. ASHC is the same construct, but with a slightly different manufacturing. Cells are enriched, are transduced into CAR T cells separately and put back together at the end, 1-to-1 ratio. Liso-cel's only been available in the UK on clinical trial. It's not currently available commercially. There's limited countries, I think, CAR-T, because we've been able to modify this pathway and improve this pathway as much as possible. Patients, if everything goes okay, can actually spend very minimal amount of time in hospital now when they're having CAR-T. So we allow patients to stay within 2 hours of our hospital if their home is within 2 hours. So we would give lymphodepleting chemotherapy and CAR-T infusion in our ambulatory care unit. Once we've done the CAR-T infusion, patients have to be admitted. We admit them for 10 days as a minimum, and then they would go back to ambulatory care follow-up. So now patients can get through the CAR-T pathway actually by only being admitted for 10 days to our CAR-T ward, which I think is a significant improvement compared to when we started the program, and probably a better patient experience than most patients having autologous stem cell transplants, for example. Also, I think it's worth highlighting that CAR-T patient is not the same as an autograft patient. Some of the lines here are really a product of what's demanded of us in terms of CAR-T eligibility in the NHS. Autograft criteria have never been quite so rigid, but certainly you need a fitter patient to have an autograft. In the UK, transplant practice really is up to the age of 75 for a curative beam autograft for, say, large B-cell lymphoma. For diseases like follicular mantle, where it's really done for progression-free survival benefit, probably we do not together for British Journal of Haematology is regarding organ function. I think we can now be much more permissive about poor organ function for CAR-T. Certainly, it's quite difficult to get patients onto a CAR-T trial in terms of strict organ function, but in my real-world practice, for example, GFR, I would certainly go down to 30 to 40 mils per minute. And there is now some evidence of offering CAR-T lymphoma for patients on dialysis, for example. I think low blood counts, I do not exclude patients for CAR-T for this reason. Ejection fraction, typically it's quoted ejection fraction more than 50%, which probably I would stick to for an autograft. But for CAR-T, I would definitely go to a lower ejection fraction, particularly if fitness and performance status is preserved. Again, CAR-T trials can be quite strict about some disease-related features. So, for example, in the Zuma studies, pleural effusions and ascites are not allowed, but certainly in real-world practice, I think this isn't relevant, and certainly I would proceed. So, the most important CAR-T lymphoma trial really that's been done is Zuma 1. I'm sure most people are familiar with it. Now 5 years of data has been reported, producing this very impressive overall survival curve. And I think what's really worth noting is how stable remissions are, particularly really after 1 year post-infusion. Following 1 year, there are some events, but certainly the remissions themselves seem very stable. So I think in high-grade lymphoma, for patients who are a number of years out, I think we don't need to be quite so cautious about talking about progression-free survival and long-term remission. I think we can tell these patients that they've been cured. Toxicity is a particular interest of mine, and I think the Zuma 1 safety data is really fascinating in that there's very little activity after the first 1 or 2 years. There are very few second malignancies and very few adverse events completely. But I mean, the main adverse events that we need to be very on guard for is infections. But I think in any lymphoma patient who is having a transplant or CAR-T in long-term remission, this remains a concern. So just to highlight the UK data, the UK CAR-T data has now been published in full last year in the British Journal of Haematology. And this is just really to highlight our early experience. I think things have improved, but certainly it's very useful to talk about what happened initially. We started the UK program with access to Axicel and Tisicel, and it's up to people like me to decide which product we use. So I think it's clear that there is a UK preference to using Axicel because a lot more of it has been used since the program started. And the main reason why people don't get to CAR-T infusion, as you would expect, is disease progression. Now, I'm going to show you the curves for the two products, but I don't think we should. I mean, this is not a clinical trial. There's a huge selection bias here. People like myself and CAR-T centers, we actively chose one product over another. And we've collected the outcome data, but we didn't do a survey of exactly the reasons why people chose specific products. But certainly, if you look at the UK data, the age range is actually quite similar for Axicel and Tisicel, but I think there's probably more of a skewing towards older patients being given Tisicel. Certainly, patients with more bulky disease were given Axicel. LDH was higher, but not significantly so. And there was more patients with a high proportion of extranodal disease being given Axicel. Certainly, in my own practice, I tend to give Axicel for patients with highly refractory, rapidly progressing disease, and reserve Tisicel for patients with either very low volume or patients with significant comorbidities or the very elderly. So if you look at the third line Axicel outcomes from the UK for the first 2 years of our CAR-T program, in the end, we end up with a 12-month progression-free survival of 41.8%. If you take that equivalent number from Zuma 1, that would be 44%. So I think this is the sort of percentage we're talking about, really meaning long-term cure in our patients, which is reflected in the overall survival curve. So in the end, Axicel has performed very well in the UK. And certainly, I think we can say that our outcomes are matching Zuma 1, even though in this UK cohort, a huge number of these patients would not be fit enough for a transplant, or they would not be allowed on the contour CAR-T trial. It's very easy to become ineligible for a CAR-T trial. Tisacel, the data is a bit different. So the 12-month progression-free survival for patients that received Tisacel was 27.4%. If you look at Juliet, which is the pivotal trial reducing the license, that number was 31%. So again, fairly similar to the trial outcome, but obviously significantly less than what we saw with Axicel. So this perhaps is the reason why there is now a strong preference to giving Axicel in the UK. Again, there's been a lot of head-to-head data Good afternoon. Thank you for inviting me to speak at this meeting regarding the question CAR-T versus autograft in large B-cell lymphoma. I'm Dr. Robin Sanderson. I'm a consultant hematologist at King's College Hospital in London, and I run the CAR-T program there. So these are my disclosures. So just a reminder of the landscape for CAR-T in lymphoma. The two products that have been available for a number of years now are Axi-cel and Tis-cel. Obviously, they have slightly different mechanisms of action in terms of their co-stimulatory domain, but their target, CD19, is the same. The companies are different. And Axi-cel is available for second-line and third-line large B-cell lymphoma and low-grade lymphoma. Axi-cel is the same construct, but with a slightly different manufacturing because the T cells are enriched. And this product is available for ALL and mantle cell lymphoma. Liso-cel is an interesting product because the manufacturing is slightly different. The CD4s and CD8 T cells are transduced into CAR T cells separately and put back together at the end, 1-to-1 ratio. Liso-cel's only been available in the UK on clinical trial. It's not currently available commercially. There's limited countries, I think, giving Liso-cel commercially, Germany, USA, but most countries do not have access yet. I think most people who are familiar with CAR-T will know this, and I suppose I'm just highlighting some of the key points when we're thinking about a patient having a transplant or CAR-T, because we've been able to modify this pathway and improve this pathway as much as possible. Patients, if everything goes okay, can actually spend very minimal amount of time in hospital now when they're having CAR-T. So we allow patients to stay within 2 hours of our hospital if they're home is within 2 hours. So we would give lymphodepleting chemotherapy and CAR-T infusion in our ambulatory care unit. Once we've done the CAR-T infusion, patients have to be admitted. We admit them for 10 days as a minimum, and then they would go back to ambulatory care follow-up. So now patients can get through the CAR-T pathway actually by only being admitted for 10 days to our CAR-T ward, which I think is a significant improvement compared to when we started the program, and probably a better patient experience than most patients having autologous stem cell transplants, for example. Also, I think it's worth highlighting that CAR-T patient is not the same as an autograft patient. Some of the lines here are really a product of what's demanded of us in terms of CAR-T eligibility in the NHS, specific products, but certainly enough for a transplant, or they would not be allowed on the contour CAR-T trial. It's very easy to become ineligible for a CAR-T trial. Tis-cel, the data is a bit different. So the 12-month progression-free survival for patients that received Tis-cel was 27.4%. If you look at Juliet, which is the pivotal trial reducing the license, that number was 31%. So again, fairly similar to the trial outcome, but obviously significantly less than what we saw with Axi-cel. So this perhaps is the reason why there is now a strong preference to giving Axi-cel in the UK. Again, there's been a lot of head-to-head data done now in a variety of forms. This was an international meta-analysis I was involved with, which looked globally at the differences between Axi-cel and Tis-cel. And again, in this study, we saw better outcomes in terms of overall survival, progression-free survival, response rates, and of course, the significant difference between the two products is the rates of significant neurotoxicity. So grade 3 and above ICANS being I think is a significant finding. And actually grade 3 and above cytokine release syndrome, so the more serious forms of CRS resulting in ITU admission, is not actually different between the two products when you look at it this way. I think it's worth noting that outcomes are actually improving. This is an abstract presented at ASH, but it's in press for full publication. And it looks at the King's data, but also the UK national data, and we see very significant improvement in lymphoma CAR-T outcomes. And I think it's just worth noting, you know, when you set up a national CAR-T program, it's very challenging at the beginning. Many patients come out the woodwork who have been waiting for CAR-T, who are highly relapsed refractory. I mean, the sort of patients we were referred to at the beginning compared to what we get now, it's completely different. We were receiving patients from around the country with very significant bulky refractory disease, and we just treat people a lot earlier now. And as a result, I think this, we're seeing improvements in PFS and OS. Certainly CAR-T toxicity management has significantly evolved as well. We are intervening much earlier with tocilizumab and particularly steroids, and I think there's enough data now to show that it doesn't affect outcomes. So I think we're much more relaxed about using steroids for management of CAR-T toxicity. Which brings me to really the main question of the talk, which is regarding CAR-T versus autograft. Now, it's never a straightforward question because it's not really CAR-T versus transplant. It's CAR-T versus standard of care. ASH last year was very interesting because we saw three presentations for the three main products, liso-cel, tiso-cel, and axi-cel. The tiso-cel report was essentially negative, so I won't present that further. And liso-cel is not available, and the results were very good, but that trial was quite significantly behind this paper, which is really an incredibly important practice-changing report, and it's sort of the first time second-line DLBCL management can objectively be changed in 25 years. So this is ZUMA-7, axi-cel versus standard of care. So yes, it's important to stress this is not axi-cel versus transplant, it's axi-cel versus standard of care. So standard of care is 2 or 3 cycles of platinum-based chemotherapy followed by an autograft if patients respond with a CR or PR. And the other arm is axi-cel. Like all of the ZUMA studies, bridging was not really allowed. I mean, you were allowed to give dexamethasone or radiotherapy, but no chemotherapy bridging was allowed, which is very different to real-world practice. Certainly in the UK, the vast majority of patients will be offered bridging, I think up to sort of 80 to 90% in the paper that was published in Blood Advances earlier this year. And the primary outcome measure in this trial was event-free survival, but they also looked at overall response rate, overall survival, and certainly safety. CAR-T toxicity, I think, is very interesting. It's worth highlighting the sort of patients coming through to this study were very high risk. There was a significant proportion over the age of 65, but particularly I think it's worth noting that around 3/4 of the patients who got onto this trial had primary refractory disease. And of course, if we look at historic data, these are patients we don't think would do very well with transplant, but certainly many of them historically end up having transplant because of lack of other options. Certainly now in my second-line practice, this is what I'm seeing. The vast majority of second-line CAR-T referrals that have primary refractory disease rather than relapse within 12 months, but the eligibility does go out to relapse within 12 months of first-line therapy. So specifically, that means relapse within 12 months of the last cycle of first-line chemotherapy. If we look at the plot, it's quite striking that on the CAR-T arm, the vast majority of patients did actually receive axi-cel, 94%. But if you look at the transplant arm, only 36% of patients actually had transplant. And of course, this is because patients did not have an adequate response to chemotherapy, which seems really quite a low percentage. But in the other second-line studies, it was similar. And I think it's also really worth noting that this is not a crossover study, but this trial was predominantly done in countries where there was good access to third-line CAR-T, so the vast majority of people that did not have transplant or relapse post-transplant actually went on to have third-line CAR-T, 57% of patients, but they did so off-protocol. And when you look at axi-cel versus standard of care for overall survival, we see this significantly improved overall survival for axi-cel in this very high-risk group of patients. And this is even acknowledging that 57% of patients in the standard of care arm went on to have CAR-T in third-line plus anyway. So this is, I think, is a strong argument for the use of CAR-T second-line. And it's certainly very convincing data, in my view, that we should be offering CAR-T versus over transplant. And the caveat that this is in the identified patients who are eligible for this trial, so primary refractory and relapse up to 12 months. Again, we see significant improvements in progression-free survival. Again, very convincing curves. So really, this is a practice-changing study where we see Axi-cel is better than standard of care in terms of overall survival, progression-free survival, and really this has resulted in significant changes in our pathway in the UK. So I realise this is everything's changed with the DLBCL this year compared to the previous years. So our whole pathway has changed, and I realise some of your ability to change this depends on reimbursement and access to CAR-T, but certainly I think the point I'm trying to make is we are convinced by this data, and the regulatory authorities in the UK have been convinced by this data, so we have been allowed to immediately change our pathway. So in data not presented, there's the Polar first-line paper, which has resulted in us being allowed to use Polar R-CHP for first-line DLBCL for IPI 2 to 5, but some patients will still continue to get R-CHOP. At the point where they are refractory or relapsed, these patients should be discussed with somebody like me, so somebody that gives a transplant or CAR-T opinion in one of the big CAR-T centres. The UK has defined CAR-T eligibility on the basis of transplant eligibility, just because that was written into the ZUMA-7 protocol. So we're only allowed to offer second-line CAR-T to people who we would consider to be eligible for transplant. So in practical terms, this really means patients up to the age of 75. So now anybody who is relapsed refractory within 12 months of their last cycle of first-line chemotherapy with DLBCL or transformed follicular or marginal, we would take them to Axi-cel second line as our standard of care. Patients who are relapsed more than 12 months or have primary mediastinal or Richter's, we would still go down the conventional salvage transplant route. Our salvage of choice is 2 times RGDP. I would highlight my experience of offering third-line CAR-T. We now always make a CAR-T decision after 2 cycles of salvage. We don't continue giving salvage, changing salvage for patients who are potentially CAR-T eligible, because I think it's not in their interest. I think it's good to make a CAR-T decision as soon as possible and then just move on. Obviously, they can have more chemotherapy as bridging, which would be the norm in the UK. So we are still doing autologous stem cell transplant, and I still think there is a clear role for autologous stem cell transplant, but it's really in the patients who are less high-risk relapses. So anybody who relapses more than 12 months after first line, we still give them a transplant as standard of care, and there is some issues about specific histologies that have to go down that pathway as well. Just a little bit about post-CAR-T relapse, because people usually ask. This is my personal opinion. People who relapse post-CAR-T with stage 1 disease, we definitely give radiotherapy as standard. Other options including any remaining polatuzumab. Glofitamab has just been approved in the NHS as third line. Tafasitamab len is available. Compassionate access, R-squared is usually available, compassionate access. Checkpoint inhibitors, I personally am not very keen in DLBCL, but certainly in primary mediastinal B-cell lymphoma, I would do so. And we would consider consolidating any post-CAR-T relapse remission with an allograft, but only in very selected fit patients with a good donor. And I think, certainly before access to bispecifics, people who have primary refractory disease to CAR-T, so I'm talking about the people who are progressing day 10, 20 by the first PET scan. I'm not talking about people who respond and then relapse at the 3-month scan, but people who are primary refractory to CAR-T, often best supportive care is the most appropriate course of action, because to progress through CAR-T is a sign of really horrible disease. Whether we change this approach now that we have more access to bispecific antibodies, we will see. A little note about transplant and stem cells you have in the bank. I think there's this interesting data coming through now about how we manage post-CAR-T cytopenias. I mean, severe post-CAR-T cytopenias in lymphoma are not that common, but certainly I have a number of patients who have had quite significant issues, transfusion dependence. And now I think there's fairly convincing retrospective data, at least, that if you have cells in the bank, it's worth giving them post-CAR T cytopenias. They don't need conditioning, you can just give them. And certainly the patients that receive cells had much better outcomes in terms of infection than the other patients in this study. So, in conclusion, NHS results have shown third-line CAR T to be effective, manageable, and our outcomes are as good as the trial data since the National CAR T programme started. ZUMA-7 has changed everything this year for UK practice. We are now offering axi-cell over standard of care salvage autograft for patients with primary refractory disease and relapse within 12 months. However, there is still a role for autologous stem cell transplant for DLBCL, and certainly for patients who relapse more than 12 months, that is still our standard of care option. But there's really interesting work to be done. You know, obviously the ZUMA studies didn't allow bridging, but in real world practice, bridging is usually needed. So optimal bridging strategy is the second line CAR T, and sequencing and how we manage post-CAR T relapse, now that we've got all these privileged position of having all these increased options, I think more work needs to be determined to determine the optimum management in these patients. Just a reminder, we have a post-CAR T and BMT fellowship for anybody who's interested, and thank you for your time.
Right, so we'd like to thank Dr. Sanderson for his presentation. We go on to the next talk, which will be delivered by Professor Xavier. So Professor Xavier is a professor and head of the Department of Oncohematology at the Poitiers University Hospital in France. And his talk will be about CAR T cell therapy in myeloma. Professor Xavier, over to you.
So bonjour, Xavier Leleu, Poitiers, France. I would like to thank you, the chairperson, for very nicely introducing me. And it's my great pleasure to share our experience with the CAR T cell technology and how amazing should be the benefit you will have for your patients. Next slide, please. Here are my honorariums. So next slide, please. So you know that the target that we use these days to use the CAR T cell technology is BCMA, B-cell maturation antigen. On the upper left side of the slide, you can see that BCMA is a receptor largely, almost essentially expressed on plasma cells. It is expressed on other organs, but the difference in expression is huge in plasma cell compared to the other organs. The BCMA is a receptor for two ligands, APRIL and BAFF, that is used for the survival of myeloma. Interestingly, when you target BCMA, you block this signaling pathway for the survival of myeloma. We will talk about that in a minute, but BCMA is essentially expressed on plasma cells and also on pre-plasma cells in the ontogeny of the B-cell lymphocyte. Next slide, please. So BCMA is very highly expressed in plasma cells, but starts to be expressed in a pre-plasma cell in the last stage of the B-cell lymphocyte. And that explains why normally if you target BCMA, you will have a complete disappearance of pathological plasma cells, myeloma plasma cells, but also normal plasma cells, and for some patients also be a lymphocyte. Next slide, please. So for a CAR T cell therapy to succeed, you need to start with a tumor antigen exclusive as much as possible to the malignant cells, and you need to try to minimize, to mitigate as much as possible the clinical off-target consequence. Next slide, please. So there are many targets that could be used as very much specific to the plasma cells. Today, we talk about BCMA targeting CAR T cells, but you should know that there are other CAR T with other targets in development and, for example, GPRC5D, but not only. This is a reminder that BCMA mRNA expression is present in many cancer, but again, cancer that are related to plasma cell, essentially myeloma, are largely on top. Next slide, please. Today, we're going to talk about the current generation of CAR T cells that are on the market, commercialized. But it is true to say that there is an incredible development around the CAR T cells, and none of these incredible development that will come in the future is yet available for the CAR that we are going to discuss. Next slide, please. However, the CAR that we are discussing today is what we call a second generation CAR. The two CARs, ide-cel, Abecma, and cilta-cel, Carvykti, belongs to the second generation CAR T cells, meaning the SCSV on top of the CAR of the cells, then the cell membrane portion with the transmembrane domain and the co-stimulating ligands, and then the endo domain with the rest of the co-stimulating factors. CD3 zeta and 4-1BB are the constructs that we are going to talk about today. Next slide, please. So today we have largely access to ide-cel in many countries in the world, and an increasing access to cilta-cel. However, not for all patients. And so we're going to discuss sort of the need to select a bit the best patient for the CAR T production. Next slide, please. So the first data and the most mature data we've been working with come from the CAR-MMA trial. CAR-MMA is the name of the program of all the clinical trials that have been developed with ide-cel, the CAR T coming from Abecma. That is, and you see in the upper right part, that is a regular CAR, second generation, with the SCSV that is mouse. So chimeric, but mouse, not fully human. The rest is as I've been discussing. You are going to try to leukapheresis enough cells so to ideally re-inject 450 10⁻⁶ cells. If you can do so, there's a great chance that your patient will sit in the upper curve of the figure in the bottom right panel, with a great likelihood to get a profound response, eventually MRD, negative status, and a prolonged control of the disease. Next slide, please. There's another CAR T, cilta-cel, Carvykti. The name of the program for the Carvykti development is Cartitude, and the first study performed in very advanced myeloma, end-stage myeloma, was called Cartitude-1. This study is very much known because it was really unprecedented in the matter of data provided by the company. Cilta-cel, you can see again the little figure, the little picture on the top right-hand part of the slide, is different from ide-cel. It is a second generation, and globally the construct is the same. However, the SCSV is different. There are two binding domains for BCMA when in fact ide-cel has one. And the production of ide-cel is essentially ex vivo, while the expansion of the CAR for cilta-cel is in vivo. And we will see that has a consequence to the patients. The results of cilta-cel were absolutely incredible. In Cartitude-1, patients very advanced in the disease, almost refractory to everything, with a survival that is counted in less than a year. The chance to respond was 100%. The chance to reach a complete response was close to more than 90% of the patients. And the median progression-free survival, death or relapse, was at almost 3 years, which in that population has never been seen with any drug before cilta-cel. So it is fair to say that cilta-cel seems to be better than ide-cel, although ide-cel is incredible. Cilta-cel seems to be better. Next slide. The most recent data provided last year at ASH, American Society of Hematology, and this year at EHA and ASCO confirmed what we knew of cilta-cel in very advanced end-stage myeloma, heavily pretreated patients, that the median PFS was approximately 35.9 months. And if you had reached complete response or even better, MRD negative status, most of the patients, by the way, you would have a median PFS not reached, meaning gonna be better than 3 years. Next slide, please. So what is new in 2023? Because what I have shared with you so far was actually something we already had discussed before and was known. Next slide, please. So there has been a lot of real-world data in the left-hand side with ide-cel, in the right-hand side with cilta-cel. Real-world data important because we know that when we recruit in clinical trials, we highly select the patient, and the idea was to make sure that in real-world data, we would be able, with patients that sometimes much more difficult to treat and that would never have entered a clinical trial, that we would replicate the data from what data we have obtained in the clinical trials. And that's exactly what you can see here, is that ide-cel appeared absolutely superimposable, even actually almost better in real-world data compared to CARMEMA-1. And for CARTITUDE cilta-cel, in real world, it's the same. Very interesting data, very positive, replicating what we knew from the clinical trials. These patients were truly end-stage myeloma in these 2 real-world studies. Next slide, please. So the point that I really want to share with you is that to offer a CAR-T, ide-cel, or cilta-cel to a myeloma patients is going to provide to you, physician, and to your patient and their family an incredible benefit. Once we have said that, it is true and fair to say that the earlier you're gonna offer the CAR in the disease course of the patient, the better will be the benefit to the patients. And we have 2 studies reported in 2023, CARMEMA-3, CARTITUDE-4, next slide please, that have confirmed that if you could do the CAR earlier in the disease course, in less advanced lines of treatment, then the results will be much better. In CARMEMA-3, 3rd line or 4th line, the results were pretty impressive. Again, the median PFS in the bottom left-hand side of the figure of the slide is the median PFS is only 13.3 months. Disappointing in a certain extent, but that's for all comers. If you look at patients in complete response or even MRD negative status, then the results are much, much, much better. What we have learned with the CAR also is that you need a bridging therapy between the leukapheresis and the reinjection. We call it the vein-to-vein time. You need to control myeloma disease. And for some patients, maybe even before the leukapheresis, you will need a treatment to control myeloma, to optimize the cells you're going to collect for the leukapheresis. Let's call it induction. So we'll come back to this. What we have learned from CARMEMA-3 is that the safety profile was quite impressive. Cytopenias, but we'll come back to that. Cytopenias after the injection, certain patients with infection, CRS, cytokine release syndrome, right after injection for ide-cel within hours, for cilta-cel around day 5, 7 within days, but very manageable. Next slide, please. So we had the data from CARMEMA-3. We have the data for CARTITUDE-4, second line, 2 lines, 3 lines, 4 lines of treatments, early relapse, multiple myeloma CAR-T program with cilta-cel, and the results, as expected, are even better than ide-cel, not only because the control arm performed better, but also because the CAR-T did even better. Next slide, please. Same thing, the safety profile was acceptable, not very different across CAR-T, cilta-cel, and ide-cel. However, slightly more Parkinsonism syndromes, so late neurotoxicity compared to ide-cel in cilta-cel. This graph, I wanted to show that graph to you because it shows very nicely how much, even if you have cilta-cel, probably the best CAR we have out there, but even with the best CAR, if you do the CAR earlier, you will always improve the patients. Next slide, please. And so this is important to remember. If we talk about, I'm going to do my CAR for my patients, but then how can I, the patient's going to ask worldwide, it makes sense. A patient would ask, doctor, tell me, how can I know if my CAR succeeded? How can I guarantee my CAR is going to succeed? You never guarantee a CAR is successful. However, we now have tons of data to say that if the patient had a normalized BCMA soluble serum concentration, these patients are the patients who do better. Next slide, please. And similarly, if you reached MRD negative status, these patients are the patients who do much better. So again, let's conclude this part here. If you have a patient that reached MRD negative status, you cannot guarantee that the CAR-T will be successful for years and years, but definitely it is an excellent situation. Same thing for the soluble BCMA marker, although I don't know if truly we need to monitor the soluble BCMA because we can monitor the MRD. So we don't monitor soluble BCMA. We do monitor the MRD by marrow and PET-CT for our patients, but I'm happy to answer questions on this if you wish to. Next slide, please. So where are we going in 2023 and for 2024? We are recruiting in patients newly diagnosed in the CARMEMA program and in the CARTITUDE program, CARMEMA-9, CARMEMA-5, CARMEMA-6 in transplant and non-transplant recipients, candidates, with different questions. For non-transplant, the question is, can we give an induction and then the one-shot CAR and the patient is off treatment with an excellent, hopefully, quality of life and control of myeloma disease. For transplant patient, the question is, can we replace transplant? Or can we transplant and give a CAR, sort of replacing the tandem transplant? Other questions, maybe we should get rid of maintenance and give a CAR instead of the maintenance. There are plenty of questions, and we'll see in the next years how all these studies will pan out and how what data we will get and how we will change our practice from there. Next slide, please. The one thing I believe that you will be really most struck with, and the one thing I have been most struck with, is the quality of the patient, which is absolutely incredible after day 1, 2, 3 for the patients until they relapse. And I hope you'll have the same experience. Next slide, please. So again, and I'll finish the first part of my talk here with this conclusion. Locomotion is one of the real-life study of what you can get in terms of survival for a patient if you do not use a CAR. And you can see it's absolutely terrible, 4.6 months median PFS, 12 months median OS, overall survival. So clearly the CAR will transform your practice compared to before you had a CAR. We also face an issue in myeloma, is that when you have used daratumumab or isatuximab anti-CD38 and your patient is refractory, reusing the other one, so you had daratumumab, you're going to use isatuximab or vice versa, doesn't work. We know it doesn't work now, or it worked poorly. You can see on the right hand a paper, a study that we have conducted with Joe Michael from Los Angeles, and Joseph and I, we have demonstrated that one anti-CD38 followed by the anti-CD38 was not very much active, particularly if you're refractory to the first time you were exposed to an anti-CD38. So we need new drugs. So you will have the anti-BCMA, anti-CD3 bispecific, and the anti-BCMA CAR-T. Next slide, please. Now, we still have things to look into. Next slide, please. Not everything is genius. It is genius, but not everything is genius. First of all, there are patients, and you can see on the left-hand side and the middle column, you can see that some patients have a poor response. Some patients do not reach complete response, MD status. These patients in the future, we need to improve. We need to understand, is it the quality of the cells we have leukapheresed? Is it that when we re-injected the CAR, it was not active? Or was it the CAR-T product that was not that good? Or was it an excellent result of the CAR, but because myeloma is high risk, the patient relapsed still earlier than expected? So we still have to answer the question, why do some patients not succeed to the same extent as the other? And we know that for very high-risk myeloma, where we are desperate offering a new treatment, you will see that it is not, these patients are not the best candidate for CAR because you hardly control the tumor mass before leukapheresis, you hardly control the tumor mass in between vein-to-vein time, and even when we re-inject the CAR, and even if the patient reach MD negative status, they tend to relapse after 6 months, 1 year, or 2 years. So it is important to know that you can offer a CAR to high risk, but it is not necessarily the best candidate. Next slide, please. And you have an excellent, and I'm going to be quick on this slide, you have an excellent depiction of what I've just voiced coming from the study called CAR-MMR3, where you can see that the CAR was 13.3 months median PFS, but whatever the definition of high risk genomic, revised ISS high tumor burden, extramedullary plasmacytoma, triplet class refractory, each time you go by a high-risk population, a poor risk population, a poorer risk population, you will see that the CAR is doing not as great. Indeed, any other treatment do even more poorly, but the CAR not necessarily is the best patient. So if you think about high risk, really the earlier you will CAR the patient, the better. If you think about triplet class refractory, maybe we should have CAR'd the patient when the patient was triplet class exposed rather than refractory. If there's a high tumor burden, maybe you want to debulk as much as possible, so earlier in the disease course, so you can have more option to debulk before you CAR the patients, etc. Next slide, please. It is clearly demonstrated that the more the tumor mass, and I'm not talking about high-risk genomic here, I'm really talking about 50 grams per liter, 5.0 grams per deciliter of M-spike. It is not necessarily poor risk, it is high tumor mass. So the higher the tumor mass, the more likely the product you're going to look at for us will not be as great, and the CAR once injected will not be as great. To make it simple, you're going to exhaust your CAR to debulk rather than exhaust your CAR to put the patient in MD negative status. So it is important to control myeloma with any other treatment, daratumumab, pomalidomide, carfilzomib, bortezomib, lenalidomide, etc., before you leukapheresis induction, before you re-inject bridging therapy, vein-to-vein treatment. Next slide, please. So it is important to reduce the tumor mass. Next slide. And in my practice, my colleagues might criticize, but in my practice, I select the myeloma patient in the relapse setting according to existence of a potential treatment to control the tumor mass prior to apheresis and to control further the tumor mass in between apheresis and reinjection. If the patients have no treatment available, I do not CAR the patient. I offer these patients a bispecific. And I regret that the patients were not sent to me earlier. But if a treatment is available, bortezomib, pomalidomide, dexamethasone, even a venetoclax-based treatment, daratumumab, isatuximab-based treatment, carfilzomib-based treatment, but if there is a treatment to control tumor mass for the myeloma disease, then to me, it's a perfect myeloma candidate. In Europe, we can do CAR after 4 lines. So no, sorry, after 3 lines, 4+. But we do the CAR often at 3 line plus. So we have more option to treat myeloma to control the disease, and also because at 3 line plus, it's already very late to do a CAR. So the earlier the possibilities, the better the better candidate is a patient for CAR. Next slide, please. We have demonstration to that. The CAR-MMA2 program and the CARTITUDE-2 program have looked into patients first line and in second line, and we can see how better are the results. And I picked here the ID cell, the CAR-MMA2 as an example. CAR-MMA2 C2C were corresponded to patients that were post-transplant upfront, not responding very well to the transplant. So technically speaking, poor risk. And in fact, if you look at the CR rate, you can see it's 74.2%. In the CAR-MMA3, in CAR-MMA3, it was below that, and in CAR-MMA1, it was 30%-ish. So even if the patients are higher risk or poorer risk, if you move the CAR earlier and potentially one day up front, you will improve these patients. And maybe at some point, I will come here and say, well, even for high risk, CAR-T works very well because we have found the best timing to do the CAR. So the earlier, the better. In Europe, we can do at 3rd line. So it's better to do at 3rd line instead of 4th, or 4th instead of 5th. Next slide, please. And so that slide, this slide shows exactly what I'd explained. Next slide, please. We need to improve the CAR product. Next slide, please. So there are various ways to improve the CAR product. And actually, because the physicians and the scientists, more importantly, are quite genius, there are like a million options of how to improve the CAR product and the patient, etc. And there are lots of science in looking into trying to do things better. But one thing you need to remember is that, and I think there is no reason it would be different for Saudi Arabia compared to France, which is that when you look after your patient, the time it takes for the cells to come back to your center, the vein-to-vein time, right now in France, it's 2 to 2.5 months. So one thing we wanted to improve is to make this turnaround for the cells to come back to the center and be reinjected much shorter. Novartis, with this PHE885 product and this new way of CAR-T, of doing the CAR, the T-Charge platform, have demonstrated, next slide please, that not only they can enhance the number of CD4 and CD8 that are T cell memory, less in exhaustive shape, more in pre-exhausted, more in active/naive status. So not only they can enhance this number of cells, but next slide, please, but also the turnaround is very short. I was very, very surprised. In 8 days, 1 week, I got my cells back. This was incredible because I was used to 2.5 months. I was used to 8, 9, 10 weeks. And with this product, it came back in 1 week. So we'll see if that has positive consequence to our patients, our practice, and the quality of the CAR. But if that turns out to be very positive, then it's going to be a great plus. And so far, my gut feeling is that maybe this Novartis product is as good as a cilta-cel, but the turnaround is much shorter. So hopefully this will conclude nicely. Next slide, please. There's a lot of future direction, and I'm not going to spend time on this because for the sake of time, and because I want to discuss to my last 3rd piece of my talk. Next slide, please. So CAR-T is a team effort. CAR-T needs patient selection, and CAR-T needs patient and team education. Next slide, please. So one thing that was very nice with the CAR is that we have created a coordinating team for the CAR to help us manage a patient that we sometimes never known before, to meet the patient, explain the patient, educate the patient, reassure the patient, organize leukapheresis with the pharma company and our leukapheresis team. Then organize a bridging therapy in the original center, community-based center, or in our center. Then the cells are back. We know the cells are back. The pharmacy, the central pharmacy, now the cells are back. And we're all aware that the cells are back. And we can move on with the next next step, which is lymphodepletion, a bed, hospitalizing the patient, organizing what is needed for the lymphodepletion, and then a special nurse on the day of the reinjection. And then the patient is hospitalized to monitor the CRS, cytopenias, risk of infection, potential neurotoxicity side effects, and then the patient is released, but we need to continue monitoring the patient. It needs a team effort, and it is something that is great because it's always good to learn to now how to work as a team and not always as a physician facing a patient. Next slide, please. I'm not going to spend too much time on side effects. The number one side effect you want to monitor is the cytokine release syndrome. With ID cell, it happens, it develops within hours. You reinject at 11 a.m., starting 2, 3, 4 p.m., 6, 8 p.m. in the night, in the next night, you may have a fever that will develop. Most of the time, very well tolerated fever, but fever. Grade 1, Lee classification of CRS. If the patient starts having hypertension, feeling worried, etc., you probably changing to a grade 2, and it's not good. We respect, we monitor grade 1 Lee classification CRS, but if it lasts for very long, if the patient maintain at 40 degrees Celsius, 41, then we treat even a grade 1. We don't wait for the grade 2, because if you wait for the grade 2, then you may lose the control of the CRS. So when the CRS grade 1 lasts for hours, we treat. You can treat with tocilizumab, anti-IL-6 receptor immunotherapy. You can treat with tocilizumab plus dexamethasone. You don't want, with a CRS from a CAR-T, to treat with dexamethasone only. You do not want to give dexamethasone only, either toci or tocidex. Dex, 10 milligram. And then you monitor. Maybe the CRS will resume the next day, and either you monitor or you retreat. It's not very good to give tocilizumab every hours. It's probably better to wait 6, but even more, 12 hours before you do again a toci injection, because at some point you inject toci, but it's not working at all. The cytopenias that are following the lymphodepletion, the CRS storm from the bone marrow, and maybe the CAR rejection, etc., on a poor marrow reserve, last for a month. They could be very profound. Sometimes they last for more, but they are rarely complicated by bleeding, anemia issue, or infection for the neutropenia or lymphopenia. So stay calm, even if the cytopenias are very profound. And of course, you take care of the patient with all the supportive care you know of, but I'm happy to discuss this in the question part. Icons, confusion, very high fever, can happen. The treatment is a treatment of the CRS. Parkinsonism syndrome, I'll discuss this in the question part. Next slide, please. Infection is rare. It can happen, it is rare. If you give polyvalent immunoglobulin, the patient will improve. If you prevent pneumocystis, herpes zona, and upper respiratory infections, particularly in Europe, maybe less in Saudi Arabia, but particularly in Europe, you will sort of prophylactize the patient against this type of infection that can develop within the first weeks, months after you have released the patient because of the profound cytopenia induced by the lymphodepletion, the CAR, the poor marrow reserves, etc., the cytokine storms and the CAR, etc. So infection is something you want to monitor. Infection is not something you want to worry about. Next slide, please. It's actually great. It's actually very interesting that, oops, there is a problem with my right-hand figure. It has shifted. It should be a quarter of turn on the left, but doesn't matter. What we were showing here is a very interesting work published now that showed that we feared the risk of infection. And I'm not saying the risk of infection is not present in myeloma under CAR-T program. It happens. But you can see on the left part of the slide that it decreases, the risk decrease, the incidence decrease over time with the CAR. While on the right-hand side, normally what you should be seeing is that with the bispecific, the risk not only exists from scratch, but also increase over time. And it takes some time before the risk of infection on bispecific sort of stabilized and decreased. So I'm not saying you will not experience infection with the CAR. I'm saying that you should not experience much infection or potentially even no infection. Still, you need to monitor. Next slide, please. Extramedullary disease, plasmacytoma. Plasmacytoma with myeloma, either bone plasmacytoma, PMD, paramedullary, or soft tissue other organ plasmacytoma, EMD, extramedullary disease. This is terrible. The prognosis of these patients is crazy, very poor. And the benefit of the CAR is limited. Often, the CAR will wipe out these plasmacytomas, but they relapse within 6 months, a year. It is not a reason not to give the CAR. It's fair to say that we need to find a way to improve the CAR, potentially by giving other treatment after the CAR injections to strengthen the effect of the CAR for these patients. This is a poor prognostic marker. It will remain a poor prognostic marker even in patients that had a CAR. Next slide, please. If one of the problems of the CAR, and I'm almost done in my talk here, is that some of the patients cannot get a leukapheresis. Some of the patients had been leukapheresed, but cannot be re-injected. If you treat the patient earlier, you'll stay away from this really crazy situation. If the later you CAR a patient, the more it'll take time for a patient to be CAR, the more likely you may experience this very sad situation where the patient wants you want, but you fail. And so, again, as I've said again, most important piece of my talk here is that the earlier the CAR, we CAR in third line. We give a treatment to control myeloma. Once myeloma is controlled, we leukapherese. We continue the treatment to control myeloma, and then we re-inject the patient. We completely stop the treatment to control myeloma because a CAR is a living drug, is the new treatment. And then when we re-injected the patient is doing great. This is the greatest situation to CAR patient. This is the most, I would say, the word is not coming to my mind here, but it's very reassuring. It's really great to see the patient improving if you do things this way. Next slide, please. The bridging therapy, next slide, please. You can give any drug you want. There is no demonstration today that one drug is better than another, but you want to avoid giving an anti-BCMA. Do not give an anti-BCMA, even probably an ADC. Probably ADC, anti-BCMA, for example, belantamab mafodotin, antibody drug conjugates, BCMA targeting. Probably you could give that and it will not hamper the activity, but you want to stay away from that, if you can. But then giving an anti-CD38, daratumumab, isatuximab, lenalidomide, pomalidomide, a proteasome inhibitors, carfilzomib, bortezomib, or even venetoclax, it doesn't seem to be really a problem. At least today, we have no demonstration that it creates issues in collecting or reinjection or following the patient. Maybe in the future we'll be able to have a better view of that. But right now, the most important thing is avoid myeloma progression before leukapheresis and before reinjection. Or if myeloma progress, it should be slow. It should be limited tumor burden increase. But massive radiorapid tumor burden increase prior leukapheresis, prior to leukapheresis, and prior to reinjection is really what you want to avoid now. Next slide, please. So then there is no great and bad treatment. You want to avoid also corticoids. You want to avoid alkylating agents because you want to avoid the risk of infection once you have lymphodepleted your patient and re-injected your patients. But again, as I've said, besides saying this, the most important aspect here is control of myeloma before leukapheresis, before re-injection. No drug is considered better or worse. No anti-BCMA if possible, no alkylating agent if possible, no corticoids if possible. Next slide, please. I'm almost done. Next slide, please. We are learning now a lot of things on resistance to CAR. As I've said, patients may not respond or poorly respond. As I've said, patients may relapse earlier, 6 months, 1 year, very disappointing. As I've said, high-risk myeloma are less responsive than very good risk, standard risk myeloma. So there are reasons to that, resistance to the CAR, either because of the CAR, because of the target, because of antibodies against the CAR, because of cells fitness of the CAR that you have collected, or even what we call an immunosuppressive, non-permissive microenvironment. Next slide, please. This is something you cannot study, and even the immune mechanism of resistance. This is not something you can study in real life, routine practice today. It is something a lot of teams are working on to determine markers that will be needed or necessary to study in the real life. Today, this is science. There's nothing that I can say, you should do that or you should do that, because we don't know. Next slide, please. What we do, though, we do a marrow before apheresis, and we monitor the control of myeloma, and we know the complete genomic, ideally complete genomic, of our patients. And we also do a flow cytometry appreciation of whether in the blood of the patient, the T lymphocytes are showing a lot of exhaustion markers. We also do the same exercise in the blood, in the marrow, before we do the lymphodepletion, and a PET-CT to have an appreciation of existence of extramedullary disease, plasmacytomas, etc. Then we do the lymphodepletion, we re-inject the patient, and we try to study in the CAR product the quantity of cells we re-inject, the quantity of cells that are CAR in the CAR product, and the exhaustion marker in the CAR product. And then we monitor that in the patient after the re-injection at months 1, 3, 6, and 12. Besides this, there is nothing I can tell you that would be better, worse, etc. Still ongoing work. Next slide, please. So, well, I think we can conclude saying that novel immunotherapy, the CAR, T cell, and the B-specific T cell redirecting with BCMA as a target are going to bring a sun, and well, you have a lot of sun in Saudi Arabia, but will bring even more sun in your life and the life of your patients. And I think this is my last slide. And I guess with this, I'll thank you very much for your attention, and I'm open to your questions. Next slide, please, just in case. Yeah, that was to say that there is a new target, GPRC5D, but it was just for the sake of concluding. Next slide, please. Then that should be my bird. Voilà. Thank you very much for your attention, and happy to take your questions.
Thank you very much, Dr. Cox. Thank you. We're just a bit of time. I'll hand over to Dr. Zahra Mahsen. You're muted, Dr. Mahsen.
So the next speaker is Professor Felipe Moro. He's the head of hematology department at the University Hospital of Nantes, France, and he will talk about supportive care and CAR-T management. Prof. Felipe, you are welcome to start.
Thank you. Good evening. Can you see my screen?
Yes, we see it.
Yes? Full screen?
Yep.
Okay. So many things have already been said by Professor Leleu. So I would like to speak about supportive care in patients with multiple myeloma treated with CAR-T cells. You know that we have now plenty of options, in fact, that were approved since 2015. 27 new options are available and approved by EMA and by FDA. But for very advanced patients, you can see that we have now 2 CAR-Ts that are approved, ide-cel and cilta-cel, and these 2 CAR-Ts are targeting the same antigen, BCMA, B-cell maturation antigen. And in fact, we are using these CARs for very advanced patients, but you know that the majority of our patients are now becoming triple-class refractory very quickly, in fact, indeed, after 2 or 3 lines of treatment. For example, frontline with stem cell transplantation and lenalidomide maintenance, the patient will progress on lenalidomide and will become refractory to len. At the time of this relapse, we are going to use KD plus a CD38 antibody, KD-DARA, KD-zatuximab, until progression. So the patient, after 2 lines of treatment, is now progressing on lenalidomide, carfilzomib, and a CD38 antibody. This patient is now triple-class refractory. And what is the outcome, in fact, of a triple-class refractory patient without immunotherapy when we cannot use CAR-Ts? In fact, you can know this outcome looking at the locomotion study that was a real-life prospective trial in patients that were, the majority of them, triple-class refractory. And 248 patients were treated, were assessed, and the response rate is 30% only. And we have used more than 90 different regimens to try to control the disease, indicating that there is really no standard of care for very advanced patients. And the median PFS was very short, less than 5 months, and the overall survival is 1 year. So definitely, we need to improve on those results. And this is the algorithm, in fact, that we can use when patients are refractory to IMiD, to PIs, and to CD38 antibody. We can use now anti-BCMA strategy, either bispecific antibodies or BCMA CAR-Ts. And we have 2 CAR-Ts. We have the KAMA study with ide-cel, and Xavier Leleu showed you the results with 82% of response, incredible response rate, and a progression-free survival of 1 year, and the median overall survival with a target dose of 2 years. And recently, cilta-cel was approved. That's another CAR-T, in fact, with 2 single-domain antibodies targeting 2 different epitopes of BCMA. And this is conferring to cilta-cel a higher avidity and a higher affinity to the target. And this CAR-T was developed in the CARTITUDE-1 study. And you can see that patients were very advanced, triple-class refractory, but the median dose of CARVYKTI, of cilta-cel, is 0.7 million per kg. And in fact, that's 10 times less as compared with ide-cel. So the construct is different. Cilta-cel is not ide-cel at all, in fact. And the responses are very quick. The overall response rate was incredible, 98%. And we have heard about the update analysis of PFS and OS, and the PFS is really outstanding, almost 3 years in median for very advanced patients. And the overall survival is also incredible, in fact, 63% estimated at 3 years for overall survival. But we need to control, we need to be on the safe side as well, because those CAR-Ts are very, very active, but the two of them are associated with cytokine release syndrome. And this cytokine release syndrome is occurring, in fact, within the first week after the infusion of the CARs, when the CAR-Ts are expanding in the peripheral blood. So that's a very early complication of CAR-T cell therapy. And we have to suspect if there is either fever, hypotension, hypoxia, or an significant organ toxicity. So the patient needs to be in the hospital, and we have to monitor carefully during this first week following the infusion of the CAR-Ts. Every 4 hours, we have to control the vital signs of the patient. And we are using for cytokine release syndrome this scale, in fact, to assess the grading of the CRS from grade 1 to grade 4. And you see, that's a very simple way of assessing CRS. Grade 1, that's fever alone above 38 degrees, without hypotension, without hypoxia. As soon as you need some vasopressors, as soon as you need oxygen, there is a grade 2, in fact. And you see that for grade 1 or grade 2, that's a quite simple assessment, and also we can easily control the CRS. Grade 3, the patient needs to go in the intensive care unit. And what are the rates of CRS? In fact, with those two CAR-Ts, in the KAMA study, in the CARTITUDE study, you see that more than 80% of the patients, 80%, did experience CRS. But the vast majority of them were only grade 1 or 2, very few grade 3, in fact. And those CRS are very predictable. With ide-cel, the median onset is 1 day, in fact. And with cilta-cel, we are infusing less cells, 10 times less. And the expansion of the CAR-Ts are occurring later, in fact, within the blood of the patient. And you see that the median onset is 7 days. So with ide-cel, very early, 1 day. With cilta-cel, 7 days. And the median duration is roughly 4 to 5 days. And in the real-life experience as well, published with ide-cel recently by our colleagues from the US, you see that the CRS rate is identical. In fact, that's 82%. So in the real-life setting, we are confirming the data from the pivotal study for the approval of those two CAR-Ts. And we can use some guidelines, in fact, and one of them were recently published, the European Myeloma Network guidelines in the Lancet Oncology a few weeks ago, how to manage adverse events during treatment with CAR-Ts. And for CRS management, that's very easy, in fact. For grade 1, you are just observing your patient, and you don't have to propose anything. As soon as you're reaching grade 2, you need to use tocilizumab. Tocilizumab, 8 milligrams per kg IV, 1 dose, and you are monitoring your patient. And in the majority of the cases, you can control easily the CRS with toci alone. If you are not controlling immediately the CRS, you can use another dose of toci, a second dose of 8 milligrams per kg IV as well. And then if the patient is not improving quickly, you can consider early dex with a dose of 10 milligrams of dexamethasone. If grade 3 or no control of a grade 2, intensive care unit immediately. But some of us are treating patients very early, as soon as we have a grade 1, in fact, in order to reduce the risk of grade 2 or 3, and TOSI alone is easily controlling a grade 1 CRS. So this is the table from the guidelines from Dr. Ludwig, and you see that for grade 1, supportive care, and we can use antipyretics in case of fever, and grade 2, administered TOSI systematically. So the guidelines are quite very simple, in fact. The second adverse event is this specific neurotoxicity, immune effector cell associated neurotoxicity syndrome, what we are calling ICANS. And in fact, this is related to the diffusion of the cytokines into the brain, and that's also very easy to grade ICANS. You have to suspect in case of somnolence, in case of confusion or disorientation, in case of seizures, for sure, or diminished attention of your patient. And you need to monitor every 4 hours, obviously. So we have to use this score, that is the ICE score. That's a score of 10 points, and that's very easy. Every day, you have to speak with your patient and to reproduce this score on a daily basis following the infusion of the CAR-Ts. The score of 10 is a normal score, and you see that the score of 4 points for orientation, you are asking to your patient, where are you? What is the date today? And the patient has 4 points if the answers are good enough. Then naming 3 points, and you are showing to your patient 1 pen, the clock, etc. And he has to tell you, this is a pen, this is a clock. So very easy and very quick as well. And a score of 1 to follow some simple commands. And you are looking as well the ability to write a standard sentence that you are proposing daily to your patient. And then attention, 1 point, with the ability to count backwards from 100 to 10. So if you have a score of 10, there is no impairment. A score of 7 to 9, this is a grade 1 ICANS. A score of 3 to 6, a grade 2 ICANS, and score of 0 to grade 3 ICANS and intensive care unit as well. So this is the I score, and you have other parameters, obviously, that you are following to grade your ICANS. And this is, again, the scale from Dr. Lee, published 4 years ago. So what about the ICANS rate, in fact, with these 2 CAR-Ts, ide-cel and cilta-cel? You see that 20% of the patients did experience some neurotoxicity, the majority of them with grade 1 or 2, very few grade 3, less than 5%. And also, the onset is quite reproducible, predictable, 2 days for ide-cel and 8 days for cilta-cel. So very often you have this sequence of CRS first and ICANS immediately following your CRS. And in the real life data set from the US group, we have exactly the same numbers of ICANS, 18% for those patients treated with ide-cel outside clinical trials. So how to manage ICANS? That's very simple as well. Grade 1, early dexamethasone. Grade 2, dexamethasone as well, 10 milligrams every 12 hours. And grade 3, you need to speak with your colleagues from the intensive care unit. And this is also clearly mentioned in the guidelines published by Heinz Ludwig very recently. Cytopenias is an issue, not a big one, but is an issue. related to the tumor burden, the involvement of the tumor cells within the bone marrow, the infiltration of the plasma cells, but also to the lymphodepletion that we are using based on fludarabine and cyclophosphamide mostly, that can lead to long period of neutropenia. And the time until blood recovery into the KARMA study for a normal blood count in median was 2 months. So that may happen early and last 6 to 8 weeks, in fact. And with cilta-cel, the majority of the patients are recovering after 1 month, in fact. For cytopenia, we have obviously to use platelet transfusion in case of thrombocytopenia, anemia, that's very simple as well. And for neutropenia, G-CSF is commonly used. And those rates of neutropenia, anemia, thrombocytopenia are really identical, in fact, when looking at the real-life data with ide-cel in the US. There is a special neurotoxicity that can occur later and is not ICANS. ICANS, that's very early. And that was reported mostly with cilta-cel. In something like 10% of the patients, we can have, after 1 month in median, a new neurotoxicity. And you can observe this adverse events with micrographia, with difficulty to walk for your patients, a sort of Parkinsonism syndrome, in fact, with bradykinesia as well. So you have to monitor carefully your patient. The patient after 1 month can be in the outpatient setting for sure, but you have to tell your patient in case of new symptoms, he has to come back immediately to the hospital. And this is related to the fixation of the CAR T cells in the caudate nucleus. And this is one case of very severe late toxicity leading to death, in fact, for this patient. What about infections? We need to use, in fact, prophylaxis systematically, an antiviral one with valacyclovir. We need also to use systematically cotrimoxazole. We are not using systematically antibacterial or antifungal. That's something that we are not doing in France, for example, but some centers can use levofloxacin or fluconazole. That's not my practice. My practice is really valacyclovir, cotrimoxazole, and a systematic IVIG replacement in case of severe hypogammaglobulinemia with an IgG level less than 4 grams per liter, in fact. But this duration of replacement is not very long. With CAR T, that's different from bispecific antibodies. You need probably only 2 to 3 months of IgIV replacement. So this is what we are doing. Consider prophylaxis during treatment, cotrimoxazole, valacyclovir, and IVIG, as I told you. And in case of fever, you have to tell your patient, please come back to the hospital if it's 1 month or 2 months after the infusion. And you need, of course, to monitor viral infection, look at CMV reactivation, EBV reactivation. You have to monitor fungal infections if the fever is above 38.5 and is lasting a long period of time. And this is also the picture from this guideline paper with cotrimoxazole, IVIG, and obviously valacyclovir as well. And I would like to thank you for your very kind attention today.
Right. Thank you very much, Professor Moreau. Right, now we have a question and answer session, panel session, where we hope to get a few questions in our chat. Until that happens, I may have a question for Professor Moreau with regards to the neurotoxicity that happens with cilta-cel, specifically the Parkinsonism. Is there any way to mitigate this? Because I think it can be quite striking and worrying for patients and for the physicians. So, you know, might there be a role for anti-Parkinsonian medication or some receptor blockade? Is that something that's being investigated to the best of your knowledge?
In fact, that's very, very difficult to predict this late neurotoxicity that is occurring in median after 1 month or 2 months following the infusion. You can probably ask your patient if there is any prior history of neurotoxicity. Obviously, if your patient has a true Parkinsonism syndrome, this is not the optimal patient for CAR T-cell therapy. And now that we have bispecific antibodies, for example, I would prefer bispecific, knowing that bispecific is not inducing any late neurotoxicity. And the current treatment of Parkinsonism, in fact, is not effective for those patients. So we cannot predict, and there is no treatment that is different from dexamethasone. Dexamethasone is the treatment of choice for those patients.
I have a question, Dr. Osman. So, Dr. Robin Sanderson, thank you for your presentation. And maybe this question can be directed to other speakers regarding management of cytopenia post-CAR T therapy. We faced this with many cases post-treatment for lymphoma. If you have a patient who relapsed early or refractory, and this patient is at risk of post-CAR T cytopenia based on the hematotoxicity score or other scores, is there any recommendation regarding collecting stem cells, auto stem cells, and freezing these cells to be used post-CAR T in these patients? Is there any recommendation regarding this? I would like to hear your opinion about that.
Was that for me? I mean, I think for us, we would certainly give stem cells if there was prolonged aplastic cytopenia, if they were available. But just in terms of if you think about the treatment algorithm, particularly with second-line CAR T, we really don't have opportunity to collect stem cells now. So if people are having third-line plus CAR T and there's cells there, then definitely we would use them. But I wouldn't. I mean, I've heard of some groups doing apheresis for CAR T and also doing a sort of a stem cell harvest at that point. But I personally think that just complicates the pathway significantly, and the focus should be getting people to CAR T as quickly as possible. So I think unless you already have them, I wouldn't build it into a lymphoma pathway personally.
I fully agree to that. We do not recollect stem cells to patients prior to performing the CAR, because I fully agree the CAR is the most important piece, and we absolutely want to move quickly to reinject the patients as quickly as possible. Now we're happy if there is some stem cells left from previous autologous transplantation that have been collected earlier on at diagnosis. But again, we do not recollect patients, and actually I haven't seen any of these prolonged cytopenias or cytopenias that have been correcting and then aplasia developing. I haven't seen that in myeloma for the past 3-4 years, to be honest. Philippe?
No, agree. In fact, that's very infrequent to need stem cell boost, and we are never harvesting stem cells just in case. If there is a prolonged neutropenia, and then if you have already stem cells that are stored from previous lines of treatment, you can use them very safely. Obviously, that's true.
Thanks. There was a question in the chat that was about cytopenias, but you've kind of answered that. I had a question for Robin about the arm in the algorithm for the second-line treatment of lymphoma. Basically, you said that you use a transplant eligibility criteria for CAR T-cell eligibility. And maybe some would question that because the CARTITUDE studies allowed CAR T therapy for patients who were thought to be ineligible or unfit for an autologous transplant because CAR T-cell therapy is supposed to be less intensive. So how do you justify that?
Yeah, I mean, it's a good question. This is just the difference between the rules that our reimbursement authorities write versus what we agree in principle. I mean, CAR T lymphoma, you absolutely don't need to be transplant eligible in terms of fitness at all. Definitely, I'm very happy to give CAR T to people who are much older, with much more morbidities. And I don't think they need to be transplant eligible. It's purely a product of what the NHS reimburses, because ZUMA-7, because in the protocol of ZUMA-7, it was written in as transplant intended. They have taken that as to be reimbursed for second-line CAR T within the NHS. You also have to be transplant intended. So this is really just an interpretation of rules applied to reimbursement decisions. But I don't think that if I could give anybody CAR T, I wouldn't follow those rules. I'm very happy to give CAR T to people who are not transplant eligible, including in second line, if I was allowed.
And in France, what are the how strict are the criteria in terms of CAR T eligibility? Do you have to be transplant eligible to be CAR T eligible, or can you have a CAR T if you're transplant ineligible?
You absolutely can have a CAR T if you're transplant eligible. The rules to CAR that are imposed to us by NSM in the compassionate, let's say, program is related to the line of treatment. So normally you must have 3 prior therapies. So you can see it as 3 prior lines, but we like to do the CAR as 3rd line. So and you get plenty of treatments in the prior 2 lines before you decide to CAR the patient. But age is definitely not a criteria to do or not to do the CAR. I actually have done CAR up to 82 and 84 years old. Truly patient that looked like 70-ish, but the oldest patients have CAR were 82 and 84, and really it was manageable. So I think it is very important not to consider that a CAR patient should be a patient that is autologous transplanting. You can CAR in much older patients if they are fit than you would transplant a patient.
Thanks. And we have one last question here from the chat, after which I think we'll go on to the next speaker in the interest of time. That is, for neutropenias, what of the role of colony stimulating agents? Should they be used or not? And related to that, were some of the same concerns that we had for GCSF and CD19 CAR T cell therapies. Does the same mechanism and do the same precautions apply for myeloma? So that's 2 questions there. GCSF, yes or no? And number 2, is it the same concerns for BCMA as it is for CD19? Is it the same mechanism? So if I might ask Professor Moreau, if you have any comments.
Yes, in fact, we for myeloma patients, we can use safely GCSF, and we are using GCSF in case of neutropenia without any risk, in fact. And the duration of treatment is very, very short indeed. You don't have to use GCSF daily because the neutropenia is not that deep. You can use GCSF every other day, and it works, in fact, without any toxicity. And this is not reacting the CRS, so you're not increasing the risk of CRS when you are using GCSF with either a BECMA or cilta-cel.
Okay, and does that is that include giving it within the first 14 days, or would you?
Well, usually we are not seeing this neutropenia very, very early. So you have this CRS from day 1 to 5, and then the neutropenia may occur at the end of the first week, in fact, and then you can safely use GCSF.
Okay. Well, thank you very much. I think with that, Dr. Mohsin, we'll probably move on to the next talk. Thank you very much to all three of you for joining us for your talks and for the question and answer. Thank you very much.
Bye-bye.
Over to you, Dr. Mohsin. Bye.
Bye, guys. Thank you very much. Have a great evening.
Thank you. So the next speaker, the fourth lecture is Dr. Nowakowski Grzegorz. Hopefully I'm reading it rightly. So Dr. Nowakowski is a consultant hematologist, Department of Internal Medicine at Mayo Clinic Comprehensive Cancer Center in USA. And his talk will be about therapy beyond the CAR-T in lymphoma.
Good evening. Assalamu alaikum. I would like to thank Saudi Society for Blood Disorders and Dr. Faraz Al-Farih for invitation to speak at this meeting. It is really a pleasure and honor to be here today. What I would like to talk today about is the treatment of patients who relapse post-CAR T-cell therapy. And this is an increasing problem as we are using more and more CAR T-cell therapy in management of patients with aggressive B-cell lymphoma. And as you will see, it's really an unmet medical need where patients are in quite dire situation and in need of novel approaches. Those are my financial disclosures. So this is a current landscape of treatment of diffuse B-cell lymphoma and aggressive B-cell lymphoma. Typically in the first line, as you know, we would use chemoimmunotherapy, and we have several options there. Recently, platuzumab, in addition to RCHP, was also approved, which is an option in addition to R-CHOP. It did not change overall survival, so we considered mostly an option. Then in a relapsed refractory setting, we really have seen emergence of the CAR T-cell use in the second line, and this is based on the data which you are very familiar with, which showed that CAR T-cells in the second line are better than standard therapy options, which would be a transplant, in patients with LD relapse, typically within 12 months post-chemoimmunotherapy. And finally, in the relapsed refractory space, we really had a revolution of now multiple new treatments. And in addition to CAR T-cells, we actually do have now antibody-drug conjugates, some targeted agents, and also novel antibodies and bispecific antibodies, which are available clinically. And those agents can be very useful in managing some of the patients with post-CAR T-cell relapse. Now, if we look at the CAR T-cell outcomes, we have to be mindful that, unfortunately, about 50 to 60% of the patients will relapse. And this was evident already from the initial studies. And this paper was published by Steve Schuster and his group, which showed long-term follow-up after CAR T-cells, and you can see that approximately 40% of the patients can be cured with those therapy in a third-line setting, and which unfortunately means that approximately 60% of the patients will relapse. And as you will see in a minute, the outcome is quite poor. If we look at the CAR T-cell use in the second line, both in ZUMA-7 and TRANSFORM trial, again, we see significant proportion of the patients relapsing after CAR T-cells. And those relapses typically happen quite early post-CAR T-cell as well, before this plateau and event-free survival, progression-free survival develops. And now a couple of papers and studies looking at the outcome of patients with post-CAR T-cell progression. And you can see that the outcome is very poor. The median overall survival in this case series was reported to be only about 5 months. And you can divide this post-CAR T-cell relapse in two groups, late and early, and particularly early post-CAR T-cell relapse, less than 30 days, is associated with extremely poor outcome, with median survival of only about 3.7 months. So what is the best treatment option for the patients with post-CAR T-cell relapse? And I showed this slide before in a couple of meetings because, if you ask the experts, people frequently will say, well, what about participation in a clinical trial? But unfortunately, as you will see, a lot of those patients will not be eligible for clinical trials, and we really have to either design the new way new clinical trials which are having much more liberal inclusion criteria, or focus on other available therapies outside of the clinical trials. So this was work done by Dr. Bazera, where he was at Mayo Clinic, and he looked at all the patients who relapsed with post-CAR T cells and at the laboratory values at the time of relapse. And you can see that majority of those patients will have profound organ dysfunction, primarily cytopenia, but also may have renal dysfunction or liver dysfunction and poor performance status as well. All of this results in the fact that only about 30% would be a clinical trials candidate for classical clinical trials. And here, we really need to develop clinical trials which are more inclusive and have more relaxed inclusion criteria, particularly in regards to cytopenias. And to make it even worse, the patients who actually did have cytopenias at the time of relapse, here in green, and were not eligible for the studies, have particularly poor outcome, with median survival of only 2 months. So really a huge unmet need. But here again, we have those no new agents which we can try to apply to treatment of those patients. And so let's just try to look at some data and understand how we can use those agents in management of those patients. So polatuzumab vedotin is frequently utilized in combination with bendamustine Rituxan in relapsed refractory lymphoma. And in this combination has about 60% response rate in patients with relapsed refractory diffuse B-cell lymphoma. There was a multi-center retrospective analysis of combination of pola plus minus BR, sometimes because of cytopenias, bendamustine was omitted and only Rituxan and polatuzumab was given. And this case series included 12 patients who have failed CAR T-cell therapy. And 7 of 12 patients actually did have response to combination of polatuzumab plus bendamustine Rituxan. So the response rate appears to be similar to what we see in patients treated prior to CAR T cells and not eligible for CAR T cells in this study, with the limitation that's based on a few patients, and a lot of those patients will be cytopenic. So bendamustine would need to be omitted in some of those patients. Selinexor is another drug which can be studied in this setting. I must say we don't use selinexor often. It's an oral therapy, but overall response rates in the studies have been reported to be quite low. But we do have some patients who have strong preference for oral therapy. And there are some anecdotal case reports, like the one shown here, that selinexor indeed may have some activity in those patients. It was noted that selinexor typically would have more activity in patients who are not necessarily chemotherapy refractory. Speaking about the pills, another pill is lenalidomide, and lenalidomide, as you know, has been extensively studied in lymphomas, specifically in relapsed refractory aggressive lymphomas as well, and it's typically associated with about 30% response rate. Here on the right, you can see study which we had done was called REMIND, when we compared lenalidomide monotherapy to tafasitamab plus lenalidomide. And the reason I'm showing it here, just to show you that in the real world, lenalidomide will benefit about 1 in 3 patients with few CRs, but nevertheless, those 1 in 3 patients who have a response can have quite durable responses. Dr. Treviemont from France was studying lenalidomide in post-CAR T-cell setting. Sometimes in this study was frequently used relatively early. And you can see that overall response rate was about 30%. With some CRs as well. So lenalidomide is another agent which could be used in those patients. Here, again, the limiting factor are primarily the cytopenias, but it's associated with about 30% response rate in this setting. Speaking about lenalidomide, tafasitamab and lenalidomide in relapsed refractory diffuse large B-cell lymphoma has been associated with the response rate of about 60%. So lenalidomide is known to synergize with different antibodies and make them better. And definitely there's a synergy between tafasitamab, antibody targeting CD19, and lenalidomide, resulting in this high activity of this combination in relapsed refractory setting. Unfortunately, we have very few data in post-CAR T-cell use. There is a couple of anecdotes described, and certainly I have my own patients too who responded well to this combination, because it does target CD19 as well, just like CAR T cells. I usually rebiopsy those patients at the time of relapse to make sure that CD19 is still expressed before using tafasitamab and lenalidomide. So potentially useful combination in this setting. Again, somewhat limiting factor could be lenalidomide here, which does cause cytopenias. And as I mentioned at the beginning, a lot of those patients will be cytopenic. Another antibody, our antibody drug conjugate, is loncastuximab desiterin. And this antibody was approved based on a LOTIS-2 study, which you can see results of here. So this antibody drug conjugate targeting against CD19 has about 48% response rate overall. So about half of the patients respond, and about a quarter of them will have CR. And you can see the duration of response and progression-free survival for the single agent therapy is quite promising as well. So definitely a useful agent in management of patients with relapsed refractory lymphoma. If you look at the specifically post-CAR T-cell therapy patients, which were included in this study, what was encouraging to me that the response rate appeared to be the same in patients with post-CAR T-cell relapse versus patients who did not receive CAR T-cell. So definitely pretty interesting data, which showed that this agent could be useful in management of those patients. I would draw your attention also to the fact that in this study, CD19 expression was required to be shown by biopsy before loncastuximab was given to the patients. So if you do it in a practice, repeating the biopsy and evaluating CD19 expression will be quite important. Finally, radiation therapy has been around since beginning of the 20th century. And sometimes myself included, we medical oncologists tend to think about the radiation colleagues as using those big, clunky, old instruments causing a lot of toxicity. But really things have changed in radiation oncology a lot. We have very modern machines now, which can really precisely deliver radiation to the area of interest. And a lot of patients with post-CAR T-cell relapses will have unusual, sometimes localized relapses, which makes them candidates for radiation therapy. Here, our colleagues from Memorial Sloan Kettering show some interesting data in regards to management of post-CAR T-cell relapse. You can see it's a relatively small patient case series, about 14 patients. And what's the most important observation here, I think, is that if you have truly localized disease, you can really achieve quite a good results of radiation. So if your patient's post-CAR T-cell would relapse with the localized disease or oligo-sized disease with just a few sites, which can be incorporated in radiation field, those patients tend to do quite well with radiation. You can see that if you have disseminated disease, the radiation is mainly palliative and doesn't really provide long-term control. So that's this important distinction when to consider radiation therapy management of post-CAR T-cell relapse. Now, immune checkpoint inhibitors, we had a huge hopes for, because if CAR T-cells are working for the immune system, stimulating immune systems, including CAR T-cells, could really alter the immune microenvironment and produce better results. It didn't really pan out in a practice. Pembrolizumab had been studied, and there was some small reports of nivolumab as well. And typically, the response rates were actually quite low. Maybe about a quarter of patients had some benefit. It was not even sustainable enough to result in a larger study. Now, having said so, there's one specific disease where PD-1 antibodies are extremely effective. That's primary mediastinal large B-cell lymphoma. As you know, primary mediastinal large B-cell lymphoma behaves like a Hodgkin's lymphoma biologically, and both Hodgkin's and primary mediastinal large B-cell lymphoma tend to respond very well to PD-1 therapy, with the response rate of about 75%. So if you do have a patient who's relapsing post-CAR T-cell with primary mediastinal large B-cell lymphoma, the agent of choice and preferred agent would be a checkpoint inhibitor, either nivolumab or pembrolizumab. Finally, I would like to finish with bispecific antibodies, and this is the therapy which I'm extremely excited about. Some people call it a CAR T cell in a vial because it brings immediately the immune cells in the proximity of the tumor. But those antibodies have many other advantages. In addition to utilizing the immune system and bringing the T cells to destroy the lymphoma cells, they can be also combined with other agents at the same time, which is more difficult with CAR T cells. So the advantage of bispecifics over CAR T cells is that you can actually add additional agents at the same time, possibly increasing response rate and activity of those antibodies. It is also relatively less toxic, although cytokine release syndrome and neurotoxicity can be seen. It's not as common, and it's easier to manage by modulating the dosing. Now, there are several antibodies in development, and 2 currently approved, and this is rapidly developing field. I'm not going to go over this data in detail here, but just to show you, for example, in mosunetuzumab, which targets CD20 and CD3, most of the antibodies currently, the ones who are approved or the closest to the approval in clinical development target CD20. You can see that this antibody results in a response rate of about 50–60%, and about half of the patients actually achieve CR. And you can see that the responses are actually seen in patients with post-CAR T-cell relapses. Now, what makes this bispecific antibodies really attractive is for CAR T-cell relapses that the incidence of neutropenia, as you see here, it does happen, but it's not very common with bispecific antibodies. And in general, you can support those patients with growth factor quite well. So if you have those very cytopenic patients with low white cell count and your hemoglobin, which is true for half, if not more, patients relapsing after CAR T cells, bispecifics can overcome this problem with cytopenia and really provide very, very useful platform of therapy. Similar data with glofitamab, that's a different antibody, again, primarily targeting C20. And you can see it's quite active antibody in relapsed refractory diffuse large B-cell lymphoma. And glofitamab was just recently approved, as was epcoritamab. So epcoritamab is actually given subcutaneously. Also, very active therapy with overall response rates of 60–70%, and about half of these responses are actually complete responses. So very encouraging data. And what's important is that the same level of response as in general population with relapsed refractory B-cell lymphoma is seen in post-CAR T-cell relapses. Again, both epcoritamab and glofitamab can cause some cytopenias, but it's not the primary problem. You can support the patients with growth factors, and really, for me in my clinic, both epcoritamab and glofitamab, which are both approved, became an agent of choice in treatment of patients with relapse post-CAR T cells. There are some other approaches which I'm not going to discuss here because they are mostly experimental. But there was a CAR T cell treatment attempt. We know that with classical CAR T cells, this was not promising, but there are some new CAR T cells targeting multiple targets, and this is being currently under study. Palliative chemotherapy is always an option, but the response rates are poor. And again, patients already have a problem with cytopenia, so it's not very feasible. And finally, in selected patients with ABC subtype, BTK inhibitors and other small molecules which are not myelosuppressive can be used. And I had some patients with ABC subtype of DLBCL which benefited from this approach. So, in a summary, the therapy for post-CAR T-cell relapse remains a huge unmet need. We really need better treatments there. Outside of the clinical trials, there are a number of options thanks to new treatments which we have now approved, including loncastuximab, desilutamide, tafasitamab, I mentioned, aplazumab, plus minus bendamustine, rituxan, some anecdotal evidence with selinexor, as you've seen. Radiation therapy for patients with localized disease is important. Good evening, salam alaikum, minus the treatment of choice for those patients right now. And the other thing what we need to do as a field is, as we are developing clinical trials specifically for those patients, we need to make sure that the inclusion criteria are open enough that even patients with the low counts can be accepted to those clinical trials to really benefit from those new agents. And I'll stop here, and I'd like to thank you again for your attention and invitation to this great meeting. Thank you very much.
Thank you very much, Professor. We will now move to our next talk, which will be by Professor Maxim Mamonkin, who is Associate Professor of Cell and Gene Therapy Center at the Department of Pathology and Immunology at Baylor College of Medicine in Texas, USA. And he will now talk about CAR T-cell in T-cell ALL. Dr. Mamonkin, over to you, please.
Okay, good afternoon to you all, and greetings from Houston. I'm Max Mamonkin. I'm a faculty member at Baylor College of Medicine. And I'd like to thank the organizers for the invitation. And unfortunately, I cannot be there in person. But today I'll talk about the development of CAR T cells for T-cell ALL and discuss the current clinical development, where we stand, and outline some future directions. These are my disclosures. So we all know that CAR T cells are working very well in B-cell leukemia, but their development in the T-cell ALL is a bit more complicated. And that's because the majority of antigens that we can target with a CAR are expressed in both normal and malignant T cells. And that increases the possibility of CAR T cells targeting each other and inducing fratricide or self-elimination, which obviously may impair their expansion. Depletion of normal T cells is a much bigger problem than B-cell aplasia, as it can lead to immunodeficiency that we cannot really compensate by other methods. And obviously, T-ALL is very frequently present in peripheral blood, and we can inadvertently modify them with the CARs during manufacture, which could lead to antigen escape. So we really need to solve all these three problems to develop safe and effective CAR T-cell therapies for this disease. So by far, the most advanced antigens in preclinical and clinical evaluation are CD5 and CD7, which are shown on this table. You can see that both of them are expressed in the majority of T-cell ALL, as well as in some mature T-cell neoplasms. And the big problem is that both CD5 and CD7 are very widely and highly expressed on the majority of peripheral circulating T cells, which predisposes them to self-targeting and elimination. However, the expression of these antigens in other critical tissues is minimal. So if we can solve these problems of cell targeting, these become very attractive target antigens for T-ALL. So we'll start with CD7 because it's expressed in the wide majority of T-ALL and lymphoblastic lymphoma. It's very bright, typically on the blasts, and is one of the best, if not the best, antigens to target in T-ALL. Just because CD7 is expressed in the majority of T cells, usually the manufacturing outline for these CAR T cells include an additional step during which the CD7 is disrupted, usually using either CRISPR-Cas9 or CRISPR base editing or protein expression blocker. So my group has shown several years ago that we can very effectively disrupt CD7 using CRISPR editing and before expressing a CD7 CAR on those, and that results in the expansion of fratricide-resistant CD7 edited CAR T cells with very high activity in preclinical models. Other reports were published around the same time using protein expression blocker by Daria Campagna's group, as well as the combining CRISPR edits with TCR ablation to create an off-the-shelf T cell product by John DiPersio's group. In the last couple of years, there have been several clinical trials reported using CD7 CAR T cells that were generated either from autologous patient material or from donors, either prior hematopoietic stem cell donors or prospective donors, as well as fully off-the-shelf third-party derived T cells. They use different methods of fratricide prevention by disrupting CD7 expression, as I showed in the previous slide. And all of them showed fantastic outcomes in patients with primary refractory and relapsed disease, showing upwards of 95% of complete remission rates in this patient. So the vast majority of these trials were conducted in China, and one just came out recently in New England Journal of Medicine, a trial performed in the UK using CRISPR-based edited CAR T cells. In the majority of these reports, the investigators noted that the aplasia of normal T and NK cells was largely avoided by repopulation with normal CD7 negative lymphocytes, which comprise a minority of normal lymphocyte pool, but in these patients, they expand and persist and resist CAR T cell targeting just because they naturally lack target antigen expression. However, the investigators still noted the increased incidence of infections, bacterial, viral, and fungal, and in some cases, these infections were lethal. In several patients, an antigen escape phenomenon was noted, just like we see CD19 antigen escape in B-ALL, so this is not unusual, but it also indicates that other targeting approaches should be developed to capture these patients. Because additional methods of fratricide prevention are complicating the generation of T cells, we've developed an alternative method in the lab where we do not really do anything else to prevent fratricide, and instead we just expand our CD7 CAR T cells without any additional editing in the presence of tyrosine kinase inhibitors, ibrutinib and dasatinib, which are very good at blocking CAR signaling that leads to fratricide. And expanding in the presence of these two inhibitors allows us to generate a lot of cells that do not produce self-targeting just because CAR is not signaling. And post-infusion, the naturally CD7 negative cells, which are a minority in the initial starting material, they survive fratricide and expand and persist. And we have validated this in mouse models, in the xenograft models of human T-ALL, where we show that these CAR T cells not just survived, but actually expanded and persisted in these animals and produced very long, durable protection against leukemia progression. So we have recently translated it to a phase 1 trial at Baylor College of Medicine, which is led by Dr. Lakisa Hill and Dr. Rain Rouse, in adult and pediatric patients respectively. We will enroll patients with T cell malignancies, CD7 positive disease. It's a standard dose escalation trial with 3 dose levels. It's designed as a bridge to allo transplant, which means that if patients achieve a response, they are recommended to proceed to an allo transplant. And then we evaluate the final CAR T cell products for the presence of CAR positive malignant blasts to make sure we're not infusing them back. And we are seeing, indeed, just like in mice, we are seeing that in human patients, our CAR T cells expand and persist long-term, and they are capable of producing very strong anti-tumor activity in patients with systemic T-ALL after a single infusion, as you can see here. Overall, we treated 7 patients on the first 2 dose levels. In the first dose level, we didn't really see any evidence of response. But in the second dose level, all 4 adult patients responded very well, including 2 MRD negative CRs, 1 mixed response with a loss of CD7, so we're also seeing CD7 antigen escape, and 1 very good partial response in patient with cutaneous T cell lymphoma. I do have to note that the responses in pediatric patients, we've treated 3 patients so far, remain quite poor because unfortunately, the patients have very high disease burden at the time of treatment, and as a result, CAR T cell infusions don't really produce a lot of clinical benefit. So what about targeting CD5? CD5 is an alternative antigen. It's also very highly expressed in TLL. It is a bit less prevalent than CD7, but it's still expressed in the majority of cases at very targetable levels. Again, just like CD7, CD5 is present in the majority of peripheral T cells, which increases the risk of fratricide, just like with CD7. However, what we found early on is if we express an optimized CD5 specific CAR, that results in very effective removal of CD5 from T cells, from the cell surface, internalization and degradation of this protein in cells. So in the end, we don't really see any evidence of the protein in our CD5 CAR T cells because this protein is being degraded all the time as it's being made. At the same time, production of RNA remains intact. And as a result of this very effective process, the CAR T cells become invisible to each other and are able to expand and persist very nicely during manufacturing. And once we co-culture them with target cells, we're seeing very nice cytotoxicity, and this is activity against circuit cells. You can see that they're eliminating the targets very well, and also producing good protection in mouse models, xenograft models of TLL in 2 different instances. So encouraged by these results, we also went ahead and translated to a phase 1 trial, which is also led by the same investigators as the CD7 trial in our institution. It has a very similar design. We treat both adult and pediatric patients with CD5 positive disease as a bridge to transplant on as a single infusion on one of the 3 dose levels indicated here. And also, just like with CD7, we make sure that we're not infusing products with detectable malignant cells that express the CAR back to the patient. So in the first cohort of patients, we treated 8 patients with primary refractory or relapsed disease. We saw very disappointing results. We saw that the CAR T cell expanded, but very quickly crashed. So their persistence was not very long. And as a result, we didn't really see a lot of evidence for response except for 1 patient in whom we did see very transient MRD positive remission, but she unfortunately relapsed very quickly after that. We started looking at the products that we infused to these patients and very quickly realized the problem, which is the CAR that constantly engages CD5 and induces its degradation in T cells. This process produces continuous photonic CAR signaling, which increases T cell differentiation. And as a result, it depletes the beneficial, minimally differentiated naive-like and central memory cells that you would normally see with control CAR T cells. In the CD5 CAR T cells, these populations were depleted. So really, the cells that produce long-term activity were lacking in our products. We have developed a method to avoid this problem using the same tyrosine kinase inhibitors that are shown in the CD7 process, ibrutinib and dasatinib, and both of them are blocking different parts, different kinases in the signaling pathway of the CAR. And as you can see in these CAR T cells, the tonic signaling from the CAR is completely blocked, and this resulted in the preservation of these minimally differentiated naive-like and central memory cells, which produced much better activity in the mouse xenograft models of TLL. So we went ahead and implemented that in the GMP manufacturing and treated several patients with CD5 CAR T cells that were expanded in the presence of dasatinib and ibrutinib, but we do not treat patients with these inhibitors. We discontinue that before the product is frozen. And so what we found out is that the products that were manufactured with TKIs expanded roughly to the same level as the non-TKI group, but persisted much, much better. The persistence of these products were much longer in these patients, in the majority of these patients anyway. And importantly, this resulted in a much better responses. So out of 8 patients that were treated with the new protocol, 6 responded very well, including 5 MRD negative complete remissions, as opposed to 1 MRD positive complete remission with the prior process. This very clearly indicates that we do require functional persistence of our CAR T cells to produce durable clinical benefit in patients with T cell ALL. And so finally, what is happening with normal T cells? Are they ablated? Just because, as I mentioned before, the majority of them are CD5 positive. We do see a reduction in the counts of circulating T cells post-infusion compared to pre-lymphodepletion. However, we never see complete ablation of these cells. And what's happening here is that shortly after injection, as CAR T cells expand, the normal T cells convert from CD5 positive to CD5 negative, and the CD5 negative T cells persist as long as CAR T cells persist. And they comprise, majority of them are CD8 positive, some of them are CD4, CD8 double negative cells, but they are polyclonal. They also express different TCRs, and we think they produce protection of these patients during the treatment. So I will conclude here, and hopefully I was able to convince you that CAR T cells that target either CD5 and CD7 are feasible, and we can manufacture them with or without additional engineering by using tyrosine kinase inhibitors, which prevent fratricide or detrimental tonic signaling. We are seeing good evidence of activity in patients with refractory and relapsed ALL and lymphoblastic lymphoma. We can increase the activity of CD5 CAR T cells by blocking the tonic signaling with ibrutinib and dasatinib. And the aplasia of normal T and NK cell subsets was limited just because we are seeing a replenishment with the CD5 and CD7 negative populations, which persist throughout the treatment. And to close, I just wanted to outline some challenges that we have observed in these patients and that can be addressed by new approaches that we and others are currently developing. Obviously, T-ALL is a very rapidly progressing disease, and frequently the patients have a lot of disease. They're filled with leukemia cells at the time of treatments. And so if we can treat them earlier and try to collect them earlier so their cells are in better shape, or maybe develop allogeneic or off-the-shelf products that will allow immediate treatments without waiting for the patient to progress, even on bridging chemo. So this is a very important area of development right now. Antigen escape, obviously, it's not a new phenomenon. We are seeing that in B-cell ALL, but it sort of raises the question, should we also use combinatorial antigen targeting, just like we use in CD19 and 22 or CD19 and 20 in B-ALL? And there are alternative antigens. We can combine CD5 and CD7, but also there are alternative antigens that could be used in combinatorial setting. And so these approaches are currently in development by our group and by others as well. Increases the frequency of infections and reactivations of endogenous viruses, predominantly herpes viruses, CMV and EBV, has been noted in patients treated with both CAR T cell products. And so that underscores the importance of limiting functional persistence of CAR T cells. We cannot let them persist for months and years like we see CD19 CARs in some of the patients with B-cell leukemia. We cannot really allow this, and we have to limit the persistence of CAR T cells either by using the right CAR design or by using suicide switches or other ways of limiting their activity. In several patients with lymphoblastic lymphoma, we did observe a limited infiltration and trafficking of our CAR T cells to the pleural cavity. These patients frequently have mediastinal masses, and sometimes we see fantastic expansion of CAR T cells in peripheral blood, but very few, if any, CAR Ts in the pleural cavity and pleural effusion. So that suggests that the trafficking may be impaired, although the number of these patients is still too low to make a definitive conclusion. And finally, is this destined to be always a bridge to transplant, and we can use that as a standalone therapy? We need to accumulate more data, and I think current evidence suggests that the lymphablation is not catastrophic, which raises the question, can we actually do it as a standalone and not mandate a transplant after this? So I will stop here and acknowledge all the people that were involved in the studies, members of my group. I'll try to highlight some of them along the way, as well as the members of GMP, GLP, the leadership of CAGT, the clinical team, which is absolutely fantastic, and the regulatory group at our center, as well as funding sources and patients and their families. I'll stop here, and we'll look forward to the discussion. Thank you very much.
Thank you, Professor Mamankin. And for the discussion session, actually, we are running behind the time. We may have only one or two questions for each speaker. So I would like to start with a question to Professor Nowakowski. Regarding the onset of relapse post-CAR T, if it is early or late relapses, does it matter regarding the decision of what treatment you will give?
This is a great question. It actually does, because the treatments, the patients who relapse early on do frequently have cytopenia. And even if they are not technically cytopenic, they tend to be much more sensitive to traditional cytotoxic therapy or any agent which is myelosuppressive. So those are the patients in whom we typically would prefer non-myelosuppressive agents. Unfortunately, there's a limited number of those, but here really the bispecific antibodies in our practice are making a big difference because the incidence of neutropenia of bispecific antibodies is pretty low, and you can maintain those patients with the injections of Neupogen or the growth factor to maintain the intensity of the treatment. Also, occasionally targeted therapy agents in those patients are useful. So in ADC patients, for example, ibrutinib can be used, and this typically not myelotoxic. So yes, to answer your question, the tempo of relapse when it happens is important. The early relapse is associated more likely with cytopenia and those difficulties in maintaining the next line of therapy in those patients.
Another question, Greg, regarding the option of allogeneic transplant. You did not mention, you mentioned it in the last slide, but would you consider this option?
Yeah, so we have a few patients now proceeding to allogeneic transplant. In general, we do not use much allogeneic transplant in the first place. It's really used in very selected individuals. So we actually prefer some of those new novel therapies options like bispecific antibodies and combinations. We have a number of clinical trials which we try to offer to patients. So yes, we have a handful of patients which would bridge to the allogeneic transplantation, and some of them do have good results. But then still less than 30% of the patients overall, at least in our experience. So we prefer the novel agents rather than allogeneic transplant.
Dr. Osman, you have a patient?
Yeah, thanks. Thank you, Dr. Nowakowski, and thank you, Dr. Mamonkin. I have a question for Dr. Mamonkin. Thank you. A very interesting presentation and very interesting work that you're doing. So now the anti-CD7 and anti-5 CAR T cells, these are autologous, right? So what is the fitness of these T cells, and especially if they have TALL, and how fit are they, and how is your starting product?
Yeah, no, it's a great question. I think you're hitting it right. The fitness is definitely reduced because we treated these patients with many lines of chemotherapy prior, and so their normal T cell compartment has been up for sure. They are still functional, as we can see, especially with the improved manufacturing, we do see nice expansion and persistence. But if we compare them with, let's say, cells from healthy donors, they are still losing that competition. In fact, we do have on the CD5 protocol, we have two arms. On one arm, we manufacture autologous products for patients pre-transplant, and then on another arm, we recruit patients who relapse post-allo, and we take cells from their healthy donors, which are essentially healthy T cells, but they're autologous to the patient's marrow. And we're seeing that even though we are infusing 10 times less cells from on the healthy arm, they're expanding and persisting actually even better than autologous. That said, the question is, how much do you need, right? And we clearly see sufficient activity with autologous products, enough to get rid of the disease. But to answer your question directly, I think the fitness is reduced, and a healthy option would be a better option. But so far, we're managing with autologous products pretty well.
And how about your view about? I'm getting a question from one of the authors of that paper, which is the UCL Great Ormond Street work that was in New England Journal of Medicine, which was quite fancy in terms of cell engineering, the base edited. T cells.
Absolutely. I think as I highlighted in the last slide, I think it is absolutely critical that we have options for patients that offer immediate treatment, and base edited CD7 CARs that can be offered off the shelf is a fantastic option. We do need to be careful though in sort of managing these patients, especially the amount of lymphablation prior to administration, because often these are allogeneic cells, and often to prevent rejection, the patients are sort of given a pretty intense chemotherapy, and that unfortunately also frequently wipes out normal T cell compartment, predisposes them to infections. And I think the authors did observe a fatal infection in their paper, and also comparable approaches done in China also observed increased incidence of these infections. So we need to be very careful of that. But if we can make a product that does not require extra lymphablation and produces just as good activity as autologous products, then I think it'll be fantastic options for this patient.
Okay, I think we will conclude the session. We are behind the time already. So thank you very much, Professor Nowakowski and Professor Mamunkin, for your talks and the discussion. And thank you to all the speakers in this virtual session today. By this, we conclude the today session, and we conclude the Congress. Thank you all the speakers, the organizer committee, and the sponsoring companies, and to all attendees. Have a good night.
Thank you
Thank
very
Thank you very much.
Thank you.
Good night. Thank you.